Thanks very much, Jolene. We always learn so much from you because we have so much emphasis on the management side of things. We are imaging people. We like the imaging side. Jolene, if I could ask you just to join. Alberto, if you wouldn't mind coming back up. Reem, if you could join us as well, please, and Fatima. So we might just open it for question and answer. If there are any questions from the floor, if we have a mic, roving mic, John or Woody, Rita. There is one question, if I could just start off with either for Alberto or for Jolene to answer, and it actually relates to a talk on a question on my talk. When you're faced with a malaligned VSD, and you have essentially a normal-sized pulmonary artery with normal flows in the pulmonary arteries, no acceleration, no evidence of pulmonary stenosis, at what point do you make a call whether you've got a malaligned VSD, or at what point do you call it a Tetralogía de Fallot, or does it matter?
Yeah, you talk about trilogy of Fallot. In these cases, we speak about biology of Fallot. We see subarterial, subaortic VSD with normal, apparently normal pulmonary trunk, apparently normal flow through the pulmonary valve. But at 20 weeks of pregnancy, for example, but you have to follow up these babies because sometimes these babies progress to and show pulmonary stenosis later on.
Yes.
So this is temporal diagnosis, first malaligned VSD, because sometimes they progress to trilogy of Fallot and eventually tetralogy of Fallot. Yeah. But sometimes it remains at subarterial VSD and they underwent surgery and so on. But this is a provisional diagnosis.
Yeah, I mean, I guess in both of these, we're going to offer genetic testing, irrespective whether it's Fallot or not, from a genetic point of view. Jolene.
I think they're two separate entities. A malaligned VSD without any pulmonary stenosis, normal outflow tracts, is a malalignment VSD. In Tetralogía de Fallot, you have a malalignment VSD plus pulmonary obstruction. So the malalignment, I have to use my hands, I don't know if people can see online. You have the septum and you have the wall of the aorta. So the aorta does this. That's a malalignment because they are not aligned. So you can have that and not have any pulmonary obstruction. But if the outlet septum does this, it has an anterosuperior deviation, it creates a pulmonary stenosis. Then it's a tetralogy.
Yep.
So you can have a malalignment VSD without that deviation, and it's just a VSD. And classically, this is what people describe sometimes as an Eisenmenger, because in the old days when they were not diagnosed, they go into pulmonary hypertension. So a tetralogy has a malalignment VSD, but also has variable degree of pulmonary stenosis. And prenatally, what you see a pulmonary artery, a clue, pulmonary artery smaller. From the screening point of view, it has got much better because the VSD can be quite difficult to demonstrate if you're doing a straight sweep from abdomen to the three-vessel view, you can miss the VSD. So the clue prenatally for screening is usually you see a pulmonary artery small and then you think, I'll go back and make sure I hadn't missed a VSD. So I think tetralogy, sometimes we overdiagnose because you can have muscle bands in the right ventricle. It turns out to be what's called double chamber right ventricle. So but the clue prenatally is a VSD with overriding and a PA smaller than the aorta. So if the pulmonary artery is completely normal, that's not tetralogy, that's a malalignment VSD.
Yes, I do agree with you, of course, but depending on the degree of malalignment, you may have either pink Fallot or a blue Fallot. So not all malalignments are absolutely equal, and there may be a progression even from pink Fallot to blue Fallot, and the pulmonary stenosis can progress even to pulmonary atresia. So that's why in some cases we apologize for making call it at provisional diagnosis because sometimes they can progress. You can not see any type of pulmonary stenosis at 18 or 20 weeks of pregnancy, but in the follow-up, usually mild pulmonary stenosis may appear. That because the pulmonary flow, as you know, increases throughout the pregnancy, and that's why in some cases this pulmonary stenosis becomes apparent only in the second half of pregnancy or even in the third trimester.
I fully agree with Alberto. And I also agree with Julen that the anomaly is there or it's not there. But in prenatal life, sometimes in second trimester, the pulmonary stenosis, it's not evident or it's just super small. And then it progresses because all the structures during fetal life need to grow. The volume, as the hemodynamics changes, no? And the right ventricle is more overloaded. And then a pulmonary stenosis that, of course, if it was there, maybe at 20 weeks, not that apparent, and then it becomes apparent or it worsens in a sense, or it's more evident.
I disagree.
In the third trimester.
I disagree.
It's okay.
I think if you have pulmonary stenosis, a degree of pulmonary stenosis that is mild in an overriding aorta, your pulmonary artery is going to be a bit smaller than the aorta.
No, yeah,
So
completely.
then
Yeah.
if it's smaller, you're already saying there is a degree of pulmonary obstruction, which could be part of tetralogy, or it could be what sometimes happens to be called a double chamber right ventricle, which are muscle bands within the right ventricle. But that means the pulmonary artery is smaller. It may be minimally smaller. It may be people don't notice it's smaller, but it is smaller.
It's good to have debate. And I think it's obviously the take-home message from it is that we need to look closely at the pulmonary artery and work out whether there is obstruction or not before we go down the pathway. But I think clinically, whatever we actually decide to call it, the management is the same. Would that be a fair comment? Is that we proceed with genetic investigations. We treat it in a worst-case scenario that it may evolve into a Fallows and get progressively worse during the pregnancy. We offer genetic testing. I mean, do you think, Julene, there's anything different that we would do if you felt it was one versus the other in the antenatal management?
No, I think from the obstetric point of view, I agree. They all need further investigation. They all have a cardiac abnormality. They all need a good fetal medicine assessment. They all need to be offered invasive tests. There's no question on that. The difference is just how you counsel them. In probably 30 years of doing fetal cardiology, I've seen 2 babies that I had to change my management from 20 weeks from this is going to be a stable tetralogy, and at the end, and I said, well, this baby's going to need neonatal surgery. 2 babies in over 30 years. So progression to a degree of pulmonary atresia is extremely rare, or nearly atresia.
I mean, I agree, and I actually didn't know that, Jelani, until I started searching, and I tell you what, it was very hard to get an answer, and I presented Papa's paper and I present Charlone's paper, the 2 paper, which the numbers were absolutely tiny, until I finally found that series, and it sort of supports what you're saying. And the numbers of babies who progress with Tetralogía de Fallot from the time we make the diagnosis to the 3rd trimester are tiny numbers. Most are stable throughout the pregnancy. And I guess that's important for us counseling patients because we're all aware in the room that things can get worse. The pregnancy progresses. But the fact of the matter on the published data and on your experience is that the numbers are small. Are there any questions from the audience? We have 12 minutes. And online, if you could please put forward your questions online.
Yeah. There is a question for Julen. So what is the...
What's the differentiating point between an AUB, aortic, and subpulmonary VSD and double outlet right ventricle?
Right, okay. I thought I had explained that, but obviously not clear enough. So when you're doing a sweep between the 4th chamber and you're coming up on your axial sweep, the most posterior vessel is the one that tells you that's closer to the VSD. So in the normal heart, if you have just a VSD with a normal heart, without any overriding. If you have a VSD in the outlet, the first vessel when you're sweeping, you get your aorta, and then you get your pulmonary artery. So if it is a subaortic, as you're sweeping upwards, the first vessel you're going to get, which is kind of in between the mitral and tricuspid valve, is the aorta. So that's a subaortic. So the other one, which is a tetralogy type, which is, as it happened in tetralogy, as you're sweeping up from the 4th chamber view, you see the VSD, and the first vessel you see is the pulmonary artery. So that's the difference. So it's the most posterior vessel. If you have transposition type, you can have the pulmonary artery coming first and the aorta coming in front of it, parallel but anteroposterior. Or you can have your pulmonary artery and you can have your aorta coming to the right. They're still parallel, but they are side by side. So the main thing is, as you're sweeping from the forechamber, which answers the question, as you're sweeping from the forechamber into the vessels, the first vessel you see, which is where is the vessel is going to receive the flow from the left ventricle through the VSD. If that's the aorta, it's subaortic. If that's the pulmonary, it's subpulmonary.
If I could maybe ask both of you, why do we classify double outlet right ventricle with the subaortic VSD as a double outlet right ventricle? Why don't we classify it as a Tetralogía de Fallot? At the end of the day, it's aortic override, and they're both treated in the same way.
Because of the degree of overriding varies as well. So for those that are the aorta entirely from the right ventricle, which is some people would call classical tetralogy, classical double outlet,
yeah.
you need a big, long patch between the left ventricle and the aorta. Yeah, so sometimes that can be a bit more difficult to repair.
Small numbers, though, Juleni, right?
Yes. So, and also the degree of overriding, depending on the angulation, you can make it 49%, 51%. So this 50% rule is created to make it easier for people to understand the physiology, but you can rotate the probe a little bit. So when it's clearly coming from the right ventricle, those are more complicated in a way because you need a long patch. So you don't want to operate on those babies too early necessarily because a long patch can affect the function.
Yeah, and the same happens for the TGA with VSD, because sometimes you may, depending on the scanning plane, you may opt for double outlet or you may opt for TGA with VSD.
Yep.
But in terms of academic, it is important to make these differentiations. But in terms of results, there are not so huge differences.
And some people sometimes say, oh, I made a diagnosis of double outlet right ventricle subpulmonary VSD, and I was wrong. It was transposition after birth with the VSD. Well, it doesn't make sense. It's the same. It just depends on the degree of overriding. So if you ever make a diagnosis of double outlet right ventricles, a subpulmonary VSD, and someone after birth, oh, this is not about it's transposition of VSD. It's the same.
Yeah, okay.
It's the same.
Yeah, but this is one aspect.
Simplistically, to differentiate TET from a double outlet with a subaortic VSD, can you use a four-chamber with asymmetry? Because in plain TET, usually you have symmetry of the ventricles. If it's double outlet, you have a large right. So for someone who's not experienced, can a large right ventricle VSD overriding vessel clue you more to DORF? Do you ever use that?
No. Unless you have a restrictive VSD of some sort, yeah? Or you have something else. But I mean, the case I showed you with both cases with double outlet with subaortic VSD, the two ventricles are more or less the same size. The one that was smaller had a restrictive VSD, so not really, no.
If I could change the direction, sorry.
I would like to make a question to Julena. And in your opinion, as we have learned a lot from for pediatric cardiologists, but to make differentiations between Tetralogía de Fallot and TGA to double outlet of the right ventricle is the continuity between the AV valve and either the aorta or the pulmonary artery. And this is lost in double outlet of the right ventricle, but is preserved in Fallot and in TGA. At what point this is a market that can be used prenatally? This continuity between the AV valve and the closer artery.
Yeah, first I'm going to say I've learned a lot from obstetricians as well. So the symbiosis there. It comes to some of my first slides. Some people would say they will only call it double outlet if you have lack of continuity between the mitral and the vessel coming, which could be the aorta or it could be the pulmonary. Other people say both come from the right ventricle. So it depends on which terminology, Van Praag, Bob Anderson, which one you want to follow. So what I try to do here is to forget about those. They can be seen sometimes in case of double outlet. So I try to look at it with the definition of both great arteries from the right ventricle, which can be more difficult to, not more difficult, but you need a bigger patch to bring that aorta into the right ventricle, to the left ventricle, or both great arteries mainly from the right ventricle. Usually one is entirely from the right ventricle, the other one is kind of overriding.
All right.
I'm just going to change the direction. We'll come back to this in a second. There's a vote of support for you on your classification of malaligned. But if I could just shift, because I want to try and keep it broad in terms of the audience. We have attendants of materno-fetal medicine and others. I want to just get your take, the panel in general, if anybody wants to answer, your take on genetic testing in the event of Tetralogía de Fallot, as to what direction you are moving in terms of chromosomal microarray, NIPT, offering it, as I mentioned earlier on, exome sequencing. Does anybody, maybe Fatima, if you maybe want to kickstart on your thoughts on that?
Yeah, so in the case of Tetralogía de Fallot as major anomalies, we always offer CBS or amnio.
Yep.
And then we just go for PCR and then microarray always. And then if we find something else, I mean, another anomaly in another of the organs of the baby, or if the baby is severe UGR also, if we find something else, then we go for the exome. Or if it's recurrent, if it's a familiar thing.
And
then
for
we go for
isolated TGA, non-syndromic TGA, are you in support of? Because I know Mary Norton presented last ISUOG suggesting looking for Notch1 and FLT4 single gene mutations in isolated fallows, and that they were offering that. And I was thinking, I don't think we've reached that in Australia.
Yeah.
And I don't know whether the audience feels and sits with that, but I don't know in Spain whether you offer or...
We are not offering that at this point. I don't know, Alberto.
We are not offering invasive testing in simple TGA. We never offer invasive testing.
But for fallow, I'm talking about for fallows.
For fallow, yeah, for fallow always.
Yep.
We offer invasive testing, even if it's isolated.
But do you
always.
move to the next level of genetic investigation with exomes, or just stop
No,
at CLA?
only when there are associative
Multiple.
findings.
Okay.
Yeah.
Okay.
Ravi has a comment.
Rabi.
Please.
Not on genetics, but on the conditions of a right aortic arc in tetralogy of Fallot. We don't see the ductus arteriosus. The question is it absent, or is it the right ductus arteriosus communicating from the right pulmonary artery under the aortic arch? So I write always, it's probably a right aortic, so right ductus type, but some will pretend there is no arterial duct. So what is your experience? Or Giulini from postnatal studies. So.
Well, if I talk firstly to it, it's a very relevant point, Rabi, because once you have that right aortic arch, you ask, is there a right arterial duct, and is it sitting inferior to the right aortic arch? And I made that point in that slide, is that you will find with these, because it's far more likely that you're going to have native pulmonary arteries and a trunk that's fed from the duct than you have no duct and collaterals. Yeah. And the importance of when you see that with the right arch is that you need to look with colour to see that behind the aorta inferior to it. And if you can't see it on a 3-vessel tracheal view, that's when you switch to sagittal looking for the duct. And that was, I guess, the key take-home message. I don't know, Jolene, if you want to...
I think it's just more difficult to see the duct if you have a right arch, but I actually, in every case of tetralogy, I measure the distal duct and compare that with the right pulmonary artery, because that tells me how significant the stenosis is. You don't always get high velocity across the pulmonary valve. You only get high velocity across the pulmonary valve if you have valvar component. If you have just infundibular component, your velocity is normal, so it doesn't tell you about the significance of obstruction. So most cases of tetralogy will have a duct. There are some cases you can't see the duct, but you still see good flow through the pulmonary arteries. The only case that's duct dependent is when you see reverse flow. And sometimes the duct is very, very small, but it's still forward flow, and then sometimes it closes. So not infrequently you have a right duct. You do still have a duct, because the angulation is different. Sometimes it's more difficult to see, but you just need to look very careful for that. Very few cases do not have a duct. If they don't have a duct, and it's not an absent pulmonary valve syndrome, it's usually good forward flow through the pulmonary arteries, so those do well as well. It's kind of moderate stenosis usually.
Jolene, just coming back to this point, because as Camilla says, I agree with Jolene, malalignment VSD without the small pulmonary arteries, not Tetralogía de Fallot. So, Jolene, if you're faced with a malaligned VSD, but there's when we talk about pulmonary stenosis, it's a little bit confusing because there's two types of pulmonary stenosis. You either have infundibular obstruction from muscular hypertrophy, and you see in your short axis where you see that deviation you were saying. There's also pulmonary stenosis where you don't have that. You have a valvular pulmonary stenosis where you have accelerated pulmonary velocities. So if you're in a scenario where you see that there's malalignment and you pulse Doppler the pulmonary valve and it's sitting at 150, 200 meters a second and your short axis shows no obstruction, my thoughts just sway more towards Fallows and therefore not entirely
Well, you can call it VSD and pulmonary stenosis.
two pathologies.
Yeah, so sometimes there is a bit of, you don't always, particularly the fetus, in mid-gestation, you have a high BMI, you have a lady that's not very easy to scan, the fetus in a difficult position. We choose the best image to show here,
Yeah.
but,
course we do.
you see patients where you have a VSD with a bit of overriding, is usually less than 50%, bit of overriding, the pulmonary artery a bit smaller. Is this a tetralogy or is this a VSD pulmonary stenosis? So sometimes I say potentially tetralogy if you don't see the deviation of the outlet septum, and sometimes in mid-gestation you can't see that.
Yep.
So in terms of management, it doesn't make that much difference if you say there's a overriding aorta, let's say 30% overriding, and there is a degree of pulmonary obstruction. So this is either tetralogy or VSD and pulmonary stenosis.
Yep.
So they both need the same
Sure.
fetal medicine assessment and everything else. The prognosis is similar. You still need to close the VSD and deal with the pulmonary stenosis. Yeah, so it doesn't really make that much difference.
Yep.
I think it's important because sometimes we get obsessed on trying to put the exact name, and then sometimes it's not that clear. And I always also tell my fellows or people who is training that if you don't know the exact name, then describe what you see. No, I see this VSD, I see that. No, and even if it's several things, just describe it. And because then, as you were saying, at the end of the day, the important thing is that the management, you go to the genetics, you do the follow-up, the prognosis, and then the final name, okay, sometimes it's on the operation theater when the surgeon opens and then gives the final diagnosis.
Yep. Yeah, good point, I think, Fatima. And at the end of the day, as Alberto said, sometimes after postnatally, our diagnosis is revised by postnatal imaging, and sometimes, the postnatal imaging is revised by a surgeon who tell you, your imaging wasn't quite what we saw. So at the various stages, there's not entire agreement all the way, and describing what you see is a very safe thing to do.
Simon, I think we have to go for lunch.
And we have 1 minute left.
No. 1 second.
Oh, 1 second left. Okay. All right, Fatima. I'll follow suit. Yep. We might close for the session.
Just to the 5th floor to a nice terrace for the lunch.
Yeah, great. Thanks very much, Rose.
Thank you.